I'm pleased to invite Foundation's President, Kristen Tesmer, to give some welcome remarks. Thank you, Kristen.
Thanks, Dr. Sharma, and thank you all for being here today. Thank you for caring about substance abuse and misuse as much as all of our partners do, and we welcome you and welcome the learning that we'll have today. I need to give a few thank yous, some specific ones, and then I'd like to tell you just a little bit about what we're about and why we're here. We want to thank Conduit for sponsoring this event. Conduit manages the healthyintexas.org website for us, which houses a lot of our community health information here in a 16-county region, and they've graciously sponsored this event today. Thank you. You'll be hearing from them later today. We want to thank Jen for being here from San Francisco. No, it is not nicer here than in San Francisco at this time of year, so thank you for your support and for being here for us. I also need to thank Scottish Rite. Scottish Rite has generously provided this space to our organization and many others in the community to share information and become better together. They provide this space at no charge. They are kind and helpful, and they have wonderful equipment for us to do this work, so thank you for that. I'd also like to tell you that we have a lot of disparity issues, obviously, in behavioral health and substance abuse and misuse in our 16-county North Texas region. Our Community Health Collaborative at the Dallas-Fort Worth Hospital Council's Education and Research Foundation is really a unique regional partnership between our health systems, our local mental health authorities, NAMI, schools, community organizations, nonprofits, health departments, the United Ways, Drug Enforcement Administration, the area agencies on aging, our faith-based leadership, payer organizations. It's a very broad swath. I should not fail to mention the Department of State Health Services. And I'm grateful to our local, state, and national authorities for partnering with us on policy, just as I'm grateful to the health systems and our providers and our community provider organizations and support functions for cooperating to understand this issue better. We know that there is a lot of stigma attached not only to mental and behavioral health, but also to misuse of substances, oftentimes as a result of having mental illnesses that go untreated. We're going to talk today about the state of our part of the country, about what we face as a community in trying to help others and help ourselves on these topics. And as we listen today, I would like to have everyone keep in mind that this would not have happened without the leadership of Dr. Sushma Sharma, standing just to my left. Dr. Sharma has world experience. Dr. Sharma is from India. She was educated and worked in England and Scotland. She's been in Oxford. She went to Berkeley after that, so she's been on the West Coast. We were very fortunate to be able to work with her here. If she keeps going, she's going to end up on the East Coast and then back around the circle at a certain point here. So she is a globetrotter, but she's worked very hard for our local community in bringing this work together. So Dr. Sharma, thank you, and we look forward to learning from you and your teams today. Thank you.
Thank you, Kristen. Thank you, Kristen and Steve. It's an honor to work with you and learning from you. Appreciate it. So now we will move forward with our first agenda item, which is a brief overview of Community Health Collaborative, how we started and how this journey has been. So back in 2010, community leaders and experts in healthcare arena got together to discuss how do we collaboratively and coordinate, how do we coordinate better, and how we collaboratively address health disparities in our community. What do we do? And they chose Dallas-Fort Worth Hospital Council Foundation to convene this committee and develop this initiative. This committee's first task was to find a common resource for community health data, because everyone was working in silo and looking for same thing in the community. So they decided to develop a combined resource where everyone can find this information about our community. Because if you want to address health disparity in a community, you need to know where we are and what those disparities are. So Healthy North Texas website was developed. It was sponsored by Health Systems and is still a great community resource in our community, and it's growing every year. So it started with 16 counties between Dallas and in DFW region. After gradually, and it was developed by Healthy Communities Institute based in Berkeley, which is now part of a company called Conduent. Then it was upgraded and expanded to 12 counties. After that community resource initiative, group decided to work on a collaborative initiative, and they chose diabetes to work together. That's how Community Health Collaborative's Diabetes Initiative was developed. Strategic planning was done, and the driving force was data, because that time, based on clinical data, 35% hospitalizations had either primary or secondary diagnosis of type 2 diabetes. So diabetes based on the information, committee decided to publish findings in Journal of Health Disparities. Several community meetings were conducted in Dallas and Fort Worth areas. Highest diabetes prevalence zip codes were identified. Some of those zip codes, they had like almost more than double of the diabetes prevalence than the national average. So CSC partnered with local community organizations who were already working in this arena in communities, both side, Dallas and Tarrant side. On Dallas side, we work with several community partners, Diabetes Health and Wellness Institute. On Tarrant County side, we collaborated with Healthy Tarrant County Community Collaborative. Based on communities' input and focus groups and what we learned from those community members and how they wanted this to be addressed, that was the key, because this was community-based participatory approach we took for this programming. We identified key disparities and what that community's disparities are, how that community wants us to help and support them to address, to mitigate these disparities. And that's how this diabetes initiative was implemented. So when this work was going on, towards the end of 2016, we decided to revisit our priorities, whether diabetes is still #1 priority for all the health systems and our community, or if anything has changed. Because that was the time when we were hearing more about mental health and substance abuse, and every single day we were looking at the reports, new reports coming in, more information coming in. So we decided to restructure CHC with our health systems, with more active participation with health systems and local community-based organizations. So we went through some strategic prioritizations in early 2017 with health systems, and we wanted to align our CSC's priorities with health system priorities and other key organizations' priorities, so we all work together on same priorities. We can coordinate better, and we collaboratively address the top priorities of our community. As you can see, these 6 priorities emerged as top priorities. Behavioral health was #1. So we decided to work on behavioral health, and that's how this behavioral health initiative of North Texas Community Health Collaborative started. And we decided to work on 3 years goals, and these were the tactics which we designed to address. To complete 16 county needs assessment for behavioral health, because we wanted to know there was no such thing available for our region, which is specific to for our region, where we can find information related to what kind of disparities we have in our 16 county region. What are the gaps, where we need to work collaborative to address key priorities, and how do we make a difference in our community. So we decided to do this 16 county CHNA. We looked into each and every source available every data set available relevant to our priority and for our community. So that was first tactics. Then adopt and begin training of 10,000 community members, health workers in a mental health first aid arena. And that was our prevention and early detection strategy for mental health in our community. I want to thank Nikki Shah, Vice President of Baylor Scott & White, for bringing this idea to Community Health Collaborative. This was a great idea, and thank you, Nikki. Truly appreciate that. Then third tactic was to create a best practice document for community activities surrounding abuse, substance abuse, and prevention and treatment best practices, which was, you will hear later, and that's the main event of the day today, that was our advisory board decided to convert this into a full CHNA, because we wanted to, we want to know more than just best practices there. We want to know where we are in first place. And then evaluating evidence-based programs with an intention and ambition to expand in severe shortage areas of our North Texas region. So 2017, we accomplished quite a few things, and I'm going to go over in next few slides quickly. So we started with forming project-specific committees. This is CHC's committee structure. We have advisory board, which is comprised of health system executives from community health and strategy areas. We meet quarterly, and this committee decides mission, vision, our moving forward, what our projects are going to be, what we want to do, how we want to address. All this strategy discussions happen in advisory board. Then we have CHC work group, and that is our key working group, planning group. That's where we implement or we do programming. How do we address these ideas? How do we transform these ideas into individual projects? And what kind of expertise we need, what kind of community partners we need to bring in. That all happens in this work group. Then we have project-specific subcommittees. CHNA committee to perform community health needs assessment based on topic. We bring expertise in, and with their support, with their help, we work on CHNAs. Then we have a mental health first aid committee, which is our 10,000 Lives initiative, training 10,000 North Texans in mental health first aid in 3 years' time. That's our goal, and we have a very vibrant mental health first committee. We have all local mental health authorities participating in this, all community partners and organizations working in this space are part of this committee. It's chaired by Lisa Boone and Ashley Rodriguez. You'll hear more about this committee in updates. And then we have a marketing committee. This is very important when you are working for any initiative regionally for 16 county geography, that we have uniform messaging. We all speak the same thing. We do not confuse the community with terminology or wordings. So we decided to have a separate marketing committee. A marketing committee regulates how publications and information will be disseminated and shared in the community. So in 2017 accomplishment, 16 counties behavioral health needs assessment is started in 2017. Mental health first aid training is started in early 2017. First training, I want to thank MHMR of Tarrant County. They were the first one to organize and execute a training at their headquarters. So first training happened in 2017 at MHMR Tarrant County. Then HCI and Conduent graciously agreed to expand Healthy North Texas website to all 16 counties. We had 12 counties covered before. Because of this initiative, we requested them to expand this to all 16 counties. So now we have all community data available for 16 North Texas counties. And then an educational event was planned for January 2018 for CHNA release. That was 2017's accomplishment as well. Now, I would like to invite Community Health Collaborative's chair, Catherine Oliveras, Vice President of Community Improvement at Texas Health Resources and Chair of Community Health Collaborative, to give us 2018's updates. Thank you, Catherine. Appreciate it.
Good morning, everyone. Wonderful to see everyone here. Thank you for being here and celebrating with us, not just the successes that we've had in 2018, but certainly the culmination of this meeting, which is sharing the Is that better? Is that better? But also sharing the results of the needs assessment that was completed this year. So I want to, again, just reiterate and thank Dr. Sharma for her leadership and the work that has happened in 2018 and what she will continue to lead in 2019 for us. So in 2018, we started off the year with a bang. In January, we launched the Behavioral Health Community Health Needs Assessment that had been worked on the previous year, and really worked to get the word out and talk about the results of that Community Health Needs Assessment. Covered 16 counties, and for those of you who may not be familiar with that work, please visit the Healthy North Texas website where you can access it. It's a really valuable tool. I know Texas Health has used it extensively, and really it has played an important role in leading a lot of the work that we're doing in place-based initiatives. So I encourage you all to take a look at it and become familiar if you haven't. Definitely one of our big successes in 2018. As part of that, Dr. Sharma and the team also worked on putting together a behavioral health providers repository for the 16 county service area that the CHNA covered. That resource is also available on the Healthy North Texas website. So again, I encourage you all to go and check that out. It's really eye-opening in terms of giving us a nice overview of the disparities that exist as it relates to providers in our 16 county service area, and also gives you specific information in terms of who's where and who's doing what. So a valuable resource. Another success we had in 2018 was a funding award that we received for mental health first aid training. So the training will be focused in 12 rural counties in North Texas with a total goal of 1,300 individuals being trained through this funding support. So again, thanks to Nikki and her idea and bringing it to the collaborative, we have really grown it, moved forward with it. Ashley and her leadership in terms of the committee has really helped us get that work moving forward, and so we're excited about what 2019 will bring for us and future conversations in terms of sustainability. A big part of 2018 was also bringing some visibility to the work that has done and the successes that we've had. And so we had a publication through the Journal of Health Disparities Research and Practice. Also launched the annual review, the 2018 annual review for the Community Health Collaborative, resource that I encourage you all to tap into and learn more about what we've been up to. We have had presentations at national conferences and also have received some awards from some key community organizations. So it definitely has been a wonderful 2018. And so again, I just want to thank all the committee members, the chairs that have helped lead this work forward, Dr. Sharma and her staff, the interns who have been a huge part of making sure that there was always something to update every meeting on a monthly basis. And again, we just thank you all for your time, energy, and effort, and we look forward to next steps. So thank you all.
Thank you, Catherine, and I truly appreciate leadership of Catherine Olivras and Ashley Kinney, Director of Patient Services at Texas Scottish Rite Hospital. These are my two bosses on CHC, and I keep bugging them, I keep asking them things, and they have great patience with me. Thank you for that. So now I would like to invite Lisa Boone from Mental Health MHMR Tarrant County. Lisa chairs our Mental Health First Aid Initiative. And Lisa will be providing us an update on mental health first aid activities we've been doing under her, and Ashley Rodriguez from Baylor Scott and White, under their leadership. So thank you, Lisa. Appreciate it.
All right, good morning, everyone. How are you on this blustery day? How is your mental health? Well, I want to thank everyone in this room for the honor and the privilege of walking alongside you on this journey to educate the community about mental health and really unpack all the stigmatism and the rumors and the whispers that tend to go along with mental illness, and provide the community with the opportunity to learn what mental illness really is and how we can support each other. Mental health first aid is just that. It's that tool, just like CPR. It educates people, it makes people more aware of what mental illness is, what it isn't, and how we can support those that are in a position of distress or that are exhibiting some signs and symptoms. It really demystifies things. So I have the honor and privilege of being one of the chairs of a committee of brilliant and passionate individuals and folks throughout the community that are moving the initiative forward to train 10,000 people in the 16-county area. Thus far, we've trained about 3,500. We have about 30 organizations and individuals that are involved. We have about 45 trainers that are poised to continue to move this forward. If you think about what our overarching goal is, it's to train 10,000 people. And so we come together on a regular basis to figure out the best way to reach out into the communities, to identify other champions, to educate them about this cause, and move forward within these communities to ensure that people are learning about mental health first aid, and they're in a position to better address issues of mental health in their communities. So I thank you very much for this opportunity. We're just getting started. We know it's year 2, but we are just getting started, and we plan to continue until 10,000 lives minimum are impacted by this wonderful opportunity. So I thank you very much.
Thank you, Lisa. I truly appreciate your help and support. Lisa is my guru on when it comes on mental health first aid program planning. And she has my number saved as Payne. So whenever I call her, that's what displays on her phone. I keep bugging her for every little thing. Thank you. Pains are good sometimes, right? Thank you, Lisa. Wonderful. When we are talking about mental health first aid, we are not only identifying opportunities to train in the community, we are also encouraging employers to train their staff members in mental health first aid. And I would like to mention here that the Community Council of Greater Dallas is the first organization who stepped up to train their staff members in mental health first aid through their training and education funds. We have Yolanda is here. Thank you, Yolanda. I truly appreciate your support, and at the same time, you being the leader of and ambassador of mental health first aid in organizations. We have trained 85 staff members for Community Council of Greater Dallas. Our goal is to train 110, and we will be also training some staff members as instructors, and that is the sustainability model when you have instructors in-house. And Community Council of Greater Dallas is also the area agency of aging. So the vulnerable people they manage, this is important for their staff to be trained in prevention, in early detection of mental health signs and symptoms for prevention strategy. And this could help reducing hospitalizations as well. So thank you, Yolanda. I truly appreciate that. Next agenda item is a unique initiative, unique effort, I would say, by our organization. Something we always talk about when we talk about mental health, because there is a stigma attached to it. And how do we address this? How do we educate our community that this is just like any other difficulty, just like any other condition? So in September 2018, the Hospital Council's President and CEO, Mr. Steve Love, was approached by a radio channel Intercom regarding the radio promos for a 2-hour broadcast, I Am Listening, a program to inspire community awareness on depression while highlighting the start of National Suicide Prevention Week. The Dallas-Fort Worth Hospital Council sponsored this event in a continuation of its 2018 mental health and substance misuse efforts in the community. We thank Steve on behalf of CHC. Steve, thank you so much for stepping up and doing this initiative, approving this initiative. And I still remember we had a very close window on timeline side. We only had 3 days to arrange everything for this. So we had 2 options, either to say too short notice or to just go ahead. But I know under Steve and Kristen's leadership, our organization is known for this thing. We never say no to these kind of opportunities when it comes on community. We knew impact is going to be high. We knew this is going to be the best thing for our community stepping up, and we somehow managed to do this. So on September 9th, the live broadcast aired commercial-free from 7 to 9 a.m. on various radio stations. The program was originated from Seattle and featured national celebrities like Michael Phelps. It also included local medical professionals who shared stories and resources. CHC members and hospital representatives who participated in this initiative were Ashley Rodriguez, Community Health Worker Manager at Baylor Scott & White, Sue Shell, Vice President and Clinical Director of Behavioral Health at Children's Health, Sherry Kusumano, Vice President of Community Education at Medical City Green Oak, Kimberly Branham, Director of Behavioral Health and Addiction Recovery at Methodist Health System, Teresita Oaks, Strategic Planning at Parkland Health and Hospital System, Catherine Olivras, Vice President, Community Health Improvement at Texas Health Resources. And thank you, Catherine, for doing this in Spanish as well. So my chair is multi-talented. I'm blessed to have her. Thank you. So on behalf of CHC, once again, we thank Mr. Steve Love and CHC's participants for this initiative. I hear a lot of good stories. I don't know if you noticed when you came here in the morning, those promos were playing up here. So great initiative. Now, with that said, this wraps up CHC's 2018 activities, and now we are moving in 2019. Now we will move on to the main event item, which is this community health needs assessment for substance abuse and misuse, where we are in our 16-county region. We will see. For that, I would like to invite CHNA committee chairs, Brad Walsh and Jennifer Gilley, on this stage. Please have a seat. I would like to invite our presenter, Mr. Scott Wells. Mr. Wells is a registered nurse and a former Medical City employee. He has just completed his Master of Public Health from UNT Health Science Center. Mr. Wells did his internship with us and helped us with this community health needs assessment. And now you can tell by looking at this report that this wasn't just an internship project. UNT Health Science Center should give him PhD. This is a PhD project. Thank you, UNT Health Science Center, for sending your best to us. We truly appreciate this collaboration. Before Scott starts his presentation, I want to thank each and every committee member here. So let me pick up my list. CHNA committee met bi-weekly. And we had very tight timeline. As always, it's never enough when you have a project like this, because you keep adding data, you keep exploring how do we get more and more data. So, and this process is still on, but we decided to share our findings with you all. So Brad Walsh from Parkland Health System is our committee chair. So this is our CHNA committee, and thank you. I want to thank each and every one of you for your time, your commitment, your support. We all exhausted all our connections in this needs assessment. From our region to even outside region. I want to thank Dr. Joanne Schulte from Houston Health Department. She is the director there, and she said she will make it to this event today, but they have mumps outbreak in one of her sites today, so she couldn't come here. We met bi-weekly to review our progress, so you can see how fast we were moving with this report. So our committee chairs are Brad Walsh and Jennifer Gilly. Thank you both for leading this effort. I appreciate your guidance. Joanne Schulte from Houston Health Department, Ashley Kinney, Texas Scottish Rite. See, you'll see my chairs all over participating in my committees. Rebecca Dyseller from UT Southwestern, Stacy Goran, Children's Health, Erica Stockbridge, UNT Health Science Center, Sonia Redwine, United Way Denton, Catherine Oliveras, Texas Health Resources, Tanisha Kennard, JPS Health System, Nicole Chesum, Prism Health, North Texas, Brett Hartkopf, Medical City, Melaine Dooley, Kindred Health System, Kurt Klinschmidt, UT Southwestern and Poison Control Center, Cynthia Velasquez, is that okay? Velasquez. Drug Enforcement Administration, Stella Coker, Methodist Health System, Kayla Fair, Texas Health Resources. Thank you all for supporting this, for guiding this initiative, and working hard. So now I would like to invite Mr. Scott Wells to come and share this presentation with us.
Good morning. How's everybody this morning? A little chilly? A little chilly in here? I agree. Once y'all stretch a little bit while I get set up, you know, get some blood pumping. Get my cheat sheet here. First of all, again, like she said, Dr. Sharma said, my name is Scott Wells. I'm a registered nurse for about 18 years. And at some point, I decided that I needed to move to a bigger picture. When you start off as a nurse, you start off with 2 patients, very easy patients, okay? As you get further along, you get sicker patients. And at some point, you become that gray gorilla, and people go to you for advice now. And then you become a charge nurse, bad mistake. And then you become an educator or a manager, or you keep going up the chain. So your view of healthcare gets bigger and bigger and bigger. For me, getting a master's in public health gave me a larger view of healthcare that I didn't have as a nurse. My interaction with Dr. Sharma started with a 5-minute phone call. Hey, can I come work with you? She's like, I don't know who you are, but sure, why not? And it's worked out to for my benefit. And I have to remember one statement that Mr. Brad Walsh said during these lots of meetings we said, is that it's a challenge to balance the clinical and the public community health. It's that bridge right here that we need to work on. And I feel through this experience, through this project, I've been able to work with that bridge, on that bridge. All right, ready? So as Dr. Sharma has already said, we looked at 16 counties. We looked at the claims data from all these counties. There we go. That was given to the data warehouse. So the data warehouse has 98 partner hospitals, and they cover about 97% of these 16 counties' healthcare hospitals. So that's a lot of data. I don't know how many data points we have, but it's millions and millions, I'm pretty sure. So what we did with this data is that they retrieved this data, and then Teresa's BI people filtered it down for me to just substance abuse, substance misuse, and then we started looking at that data. One little quick statement about our data is that this project, this data that we did, is not for a scientist, it's not for a researcher, it's not for somebody to do standard deviation or poison distribution or anything like that. This is for community leaders to have this in front of them, be able to look at what's going on in their community down to the zip code level and look for solutions. So there is no higher level statistical analysis done except noted. And all data in here is from the hospital claims data from the data warehouse unless noted. Our data and information source, like I said, the majority of it came from the data warehouse and then local, state, and national organizations. I apologize, I think like our slides have moved a little bit because we're having some coverage there, but too late now. So let's look at, when you think about substance abuse, substance misuse, what age group do you think about? That's a question. Youth, exactly. So, which we'll come back to that in a moment. So we looked at what rules, what regulation, what acts have been put in place to help youth deal with substance abuse, substance misuse. One of the ones, we briefly go over these. This is the Drug-Free School and Communities Act Amendments of 1989. Basically, it said that if you, an institution, wanted to receive financial aid, you had to have a drug and alcohol program, and you had to collect data and provide that to the government. Pretty simple. So we have an institution, prevention and treatment programs, or maybe not treatment, but programs, giving that data to the government. The next act that we want to look at is called the Jenny Cleary Act. Is anybody familiar with this? The DEA it is. So this was a young woman. She was a 19-year-old young woman at Leahy University that was raped and murdered on campus. And after this, her parents became advocates for statistics, so criminal statistics about what's going on at universities. So now, all universities have to participate in this. They have to make their statistics, crime statistics, public, like on a public website or disseminated some way. If they do not, they can be fined. So how many people has kids in college? I have 3 right now, so I really want to know. So, all right. So that's 2 quick things from education. So let's look and see what they do in the universities. And I think we have some TCU students in here. No, maybe? Okay. So in education, at all levels, all the way down to primary, secondary, community colleges, and universities, have varying degrees of prevention, assessment, and treatment. So there's a couple areas they do. Counseling on and off campus, some of the largest universities. So we looked at the larger universities and the community college systems in the DFW area. Some of them have counseling on campus, the smaller ones have it off the campus, but they have a resource, a link to go from on campus to off campus. Education in freshman, fish camp. Anybody do a fish camp? Everybody know what a fish camp is? Freshman indoctrination. It's not indoctrination, is it? It's freshman. It's the camp before kids start school. They go there to kind of say, this is where your dorm is, this is where the
Welcome week.
Welcome week, yeah. Sorry, not indoctrination. Through education, and they do that in freshmen as you transfer in and ongoing programs, and also in response to events such as school shootings or suicides. A university may ramp up their resources for that. Notes to parents. I haven't gotten any notes to parents yet, so I'm good. About their behavior on campus, all right? And there's also, these notes may be placed in the student's permanent record. I don't know if that falls in past them. A new approach from a local university, TCU, is they fine the students now. As you see, the first offense is $75, the next offense is $100 and $150. So as a poor college student, that's a lot of money, And what I find more interesting is that they find it through the bursar's office. So me as a parent that is paying the bills, I will see that. Hey, Carmen, that's my daughter, what is that? Well, Dad. No, I don't, so you're grounded. Data is collected and published in varying degrees from individual institutions, colleges, and universities. So from a quick overview of the limited data that we got from local universities, we see that alcohol and illicit drugs are the majority of substance abuse misuse events. So when you talk to your college-age kid or even your high school kid, remember, what are you doing today? So we've listed here some best practice sites based on education. So there's 2 pages of this. Some of them are local, some of them are national. Some of them are based in universities, some of them are based in think tanks. All right, so let's get some numbers now, okay? So this is from CDC Wonder, okay? So this is deaths attributed to drug, alcohol in Texas in 2017, okay? So that doesn't mean they necessarily died from alcohol. They could have died something that was related to alcohol, such as cirrhosis, or a drug too. So cirrhosis, cancer, mental illness, suicide, poisoning, motor vehicle crashes because they were under the influence, the list can go on. These numbers are quite stunning, actually, especially when you get down to the 75 to 85 range. You know, what, 95,000 of that of the 191,000 is in that age. Why do you think that is? Prescription drugs, it could be. Mental deficits, they're not working, they're lonely. The literature also says that if you have a drug alcohol issue and you have a mental illness, bipolar, schizophrenia, dementia, it's not even double worse, it's a lot bigger worse there, okay? And that's part of what builds in those numbers. So we've looked at the age groups of attributable death. Now let's look at the counties. So there are 16 counties that we looked at, and so they're in the green, and on the far right, the red is the Texas average, and I must say this is a crude rate per 100,000. This is actually calculated. This is not just numbers. And USA is 863. So you can take a look at this, and you can see that, off the top of my head, I think we counted, there are 11 counties in our 16-county region that are higher than the Texas average. Let that sink in. Attributable death by alcohol and drugs in North Texas, 11 of the 16 counties we looked at are higher than the Texas average. And if you continue over to the national average, there are 7 counties that are higher than the national average. Is that acceptable? No, it's not. So let's look at, these are total numbers, and again, I'm sorry, I see it gets cut off there. Total numbers. So after Teresa's BI department filtered down to just give me the patients that had an ICD-10 code of substance abuse, our number, so our N was 687,774. So that's the start we started for all 16 counties. So for all 16 counties, the 3 main categories we found were nicotine, as you can see it's over 500,000, alcohol, and then other. And we'll talk about other in a second. Talking about the ICD codes, they can be found at any position. So it can be a primary admitting diagnosis, or a primary diagnosis, or any further down. We went down to 25 diagnosis codes. So that the F1 code for substance abuse could be at any position. We didn't filter out if where it was. When we did our very first county, which was Somerville, it was a really small county, we actually did look to see how many hits we got, how many ICD-10 codes, substance abuse, were primary diagnosis. And it was 3, 4, it was very, very small. You know. So what happens, these patients don't come in, say, alcohol or a drug. They come in for something else, and it says, oh, you smoke, you drink, you do illicit drugs. So let's drill this down a little bit further. So this is actually the breakdown, and these are the ICD codes, descriptions on the right-hand side. Because you can see nicotine, the first 2 are nicotine, that makes up 42 and 29%. In those numbers is e-cigarettes, okay? We had a long conversations about coding with the people at UT Southwestern about what specific code goes with certain things such as e-cigarettes. There isn't one. There's a grouping of. So we kind of went around and said, how do we get it deeper and deeper, and we couldn't at this time. So, all right, so we're going to look at a special group now. So this is a special group of patients. So for this, we actually went all the way back out to the data for all 16 counties for every patient, because the ICD-10 codes for maternal and infant substance abuse are different than regular substance abuse. As you can see, we had total cases of 172,000 in 2017. Again, all this is only 2017. The infant, which is described as 0 to 1, we had 35,000 cases. 35,000 children were born with either positive toxicity or they had signs of alcohol or drug withdrawal addiction. That's stunning. Okay? So that's maternal and infant. So let's look at what our pharmacists are doing. So these are the top 10 prescriptions dispersed in 16 counties in 2017 per the Texas pharmacy records, okay? And so I've listed the drug on the left-hand side, I've listed some examples in the middle, and the number of prescriptions are on the right. So the first one, obviously, is opiate agonists, so such thing as codeine, morphine, or Vicodin. And there are just short of 5 million prescriptions written in 2017 for the state of Texas. Now, I'm not saying they were abused or misused. I'm just giving you a number. There are 5 million prescriptions written in the state of Texas.
Take 16 counties.
Oh, I'm sorry. Yes, thank you. That's why she's here to keep me in line. In 16 counties, yes, yes. The next one is benzodiazepines, which are examples are Valium and Xanax. And the third one is amphetamines, which is Vyvanse and Ritalin. So, is there any pharmacists here? Okay, what those 1, 2, 3, 4, 5, 6 drugs I listed, what group do they all fit in? Well, they're all controlled drugs of abuse. These drugs all have an incidence, higher incidence of abuse than, say, guaifenesin or testosterone or, well, dexedrine maybe does too. So the top prescriptions you have for 16 counties are all drugs that are commonly abused. All right. So this is kind of a quick summary of what we just said. We start off with 191,000 for 16 counties. 11 counties were higher than the Texas average. 7 counties were higher than the national average. So here, total cases, patient visits with substance abuse misuse. So this is my big N. Reported in 2017 was 687,774. So that's the number we started with, and then we went from there. Also, the very last thing, nearly 70-80% were outpatient visits. So these patients are going to the ER primarily and being discharged somewhere or being sent home. They're not going to a facility or being admitted to the hospital. So that's the regional focus. So let's look at a specific county. So we're going to look at Collin County. So this is Collin County, a population of about just short of 1 million. So on this screen, it gives you the top 10 high-frequency utilization patients. So what that means is that these patients go to the hospital a lot. So number one, for example, number one patient, that patient went to the hospital 42 times in 2017. 42 times. I mean, you got to work at going to the hospital 42 times, you know, at a total cost of $773,943. Now, that's not just substance abuse, misuse cost. That's all their care for those 42 visits.
Total charges filed.
Total charges filed. I'm sorry. So it's actually not even the total cost. Total charges filed. For a total of 313 and just short of 3 million. Does that surprise anybody? Okay. So let's look at some demographic of patients that we see that are substance abuse misuse. This is for Collin County. So for Collin County, there are total cases of 41,000. The average charge filed is $20,000. Most of them you can see are outpatients, so 77% are outpatients. Most of them are discharged to home, 88%. The insurance in Collin County, 45% are insured and 35% are uninsured. So that's a financial burden on Collin County.
That is a surprising fact as well.
Yes, yes. Again, more demographics. In this county, males and females were equal. You know, we're all equal here in substance abuse misuse. Race is primarily white. Ethnicity is primarily non-Hispanic. What I found really interesting, too, is that what did I say before? What's the population we think of when we think of drug abuse, misuse? Youth. But by this, that's not true. By these numbers, it's not true. The population is 26 to 60-year-old, and the 41 to 60-year-old is the highest. What I find really interesting is the 60 and above is 16%. Does anybody have an idea what that is? Remember, it's misuse, too. So misuse is defined taking a drug for what it's not intended to be. You know, so your grandparent eyes are a little bad, and they look at their pill bottle and say, "Oh, I'm going to take this for this," and they take it, and that's not what it is. That's not what it's for. That is a differentiation between abuse and misuse. Abuse is that you use a drug in a way it's supposed to be used, but more than it should be, such as pain pills. All right. Misuse is you use a drug or a substance in a way that it's not supposed to be used as, such as the cleaners for computers. The bottle of spray, what's that called? What's that? Air dusters. That's a substance abuse. That's a misuse.
So people eat that?
No, they huff it. Yeah. This audience knows way too much about this stuff. So in substance abuse misuse in Collin County, you see that nicotine is by far the largest body, the largest group. 36,000 with 3,800 in alcohol and 1,300 in other. To be more specific, again, these are per ICD-10 codes. You see the breakdown here is that there's different forms of how they're coding alcohol and other substances. But again, nicotine is by far the greatest. But we were interested in non-nicotine alcohol because of the drug epidemic, opiate epidemic. So we looked at, this is, for Collin County, and the top 3 percentages are cannabis, and other psychoactive substance. Anybody live in Collin County? So, but even if you take all this, even though it's a repeating pattern, we'll see the same thing over and over again through the counties, these total numbers are still probably 8% something of the total abuse. So now we want to look at and see in what part of Collin County are they doing this. So we looked at zip code levels. So on your left is visits. So that means that for every time Dr. Sharma went to the doctor, it counted as 1. All right, every time. Okay, and you see you have the zip codes there, and the XXX is undisclosed. That means it could have been blinded. That could mean they didn't put it in there. That could be almost anything, a clerical error. It can be, but the number is huge, 10,000. On the other side, you see patients. What that means is that if Dr. Sharma goes to the hospital 5 times this year, we count it as 1. So it's only 1 versus every visit. As you can see, the top 2 or 3, 4 are basically the same on both sides. And Dr. Sharma talked about the diabetes initiative earlier today. The zip codes they looked at then are pretty close to what the zip codes we looked here. The behavioral health CNA they finished last year, the numbers are pretty close to this. The zip codes are pretty close to this. The poverty numbers, if you look at poverty by zip code, they're pretty close to this too. So we yes?
Oh, just a quick question. So if Dr. Sharma went to 5 hospitals, is it her zip code that's counted, or is it the zip code of the hospital that she went to?
Her zip code.
Residents, based on residents.
Yeah, it's based on her. Yeah.
I-
That is a possibility, and again, these are raw numbers. We didn't do any drilling down.
Data is not adjusted for
Yeah.
population.
But if you are a provider, a community health worker, a politician, does that really matter? You see, you have 2,700 people in 75069 that have substance abuse, substance misuse.
That's your target population.
Yeah.
really. You want numbers for that.
So to answer your question, to talk to your question, is that patient migration. Now, with certain counties, we see patients go out of their representative county. For this one, we really don't. They're all these patients basically stay in Collin County. You can see,
Except Parkland.
well, except you see, so McKinney, Plano, and Baylor at McKinney, they're the 3 largest. All right.
But we do see some migration.
There is some migration to Parkland.
Yeah.
So the next group we want to look at is it's called OSAR data, Outreach, Screening, Assessment, and Referral Center data. And I am by far not an expert on OSAR, but my understanding it is a state program that is given free to providers, and that you as a patient can go to these providers and get treatment.
Your OSAR only does the screening and assessment portion,
Okay.
and then they would, the OSAR does the screening or assessment portion, and then would make a referral to a community-based provider.
Okay. So this is just some data that we were given by the state. So you look at it, and you look at what drugs they're seeing. So in Collin County, heroin is number 1. Again, this is only OSAR patients, but heroin is number 1, alcohol is number 2, methamphetamine, You think about Collin County, you think about methamphetamine? I don't. Brad may. And opiates and synthetics. And on the far right, for not every county were we giving youth data, but in Collin County we were, and you see marijuana and hashish and methamphetamines, they saw a couple patients for that too. So next we're going to look at poison control data. So this is calls to the poison control, all right, and what did they call about? Analgesia, antihistamine, sedatives, antipsychotics, antidepressants, it's kind of the top few there. Okay. So again, these may not be overdoses, these may not be, it may just be a frantic parent calling about their son or daughter took something. And it's interesting that you look at that, the largest population in Collin County that they're called about is less than 5 years. So 2,207 is the number of times the poison control was called about a 5 or under child maybe overdosing. That's kind of stunning. So why do you think that is? You think nervous parents, first-time parents? What's that, Chris? They grab stuff. They do grab stuff.
They get away from you. There's things.
Okay. So our key findings from Collin County is, again, we had a total population of 41,000. Marijuana is the most common substance in youth seeking OSAR services. Our OSAR top 5 substances are alcohol, heroin, marijuana, methamphetamines, and opiates. Nicotine and alcohol were top 2 substances reported in our data. And 66% of our visits were 26 to 60-year-old. 66 of our visits were young adult to, what's the word I can use? 60, what's that called? It's not elderly anymore, it's older adult. Okay, all right. So that's kind of the pattern that we have for this presentation and for Collin County. So now we're going to move to Dallas County. Again, Dallas County is a larger county by about 1 million. They have about 2.6 million. And you can see here the same high frequency utilization patients. The number one patient had 194 visits for a total cost of $662,537. You thought that the guy who had 42 visits had to work hard to get to the hospital. 194. I mean, this is not even every other day. It's a lot of visits. So, you know, and the question is that if we're looking at this and the uninsured rate is 50%, who's paying for these patients? What programs can we do to get them, to keep them out of the hospital? What prevention programs can, you know, what home health services can we to get them from going to the hospital and incurring these huge costs? Or if they're uninsured, us incurring these huge costs. So the demographics of Dallas County, again, our N is 214,000. Average cost is 15,000. It's 81% outpatient. Almost 90% were discharged to home. This is really interesting too. So insured is 25% versus uninsured is just say 50%. The gender, well, here the males have this one, 37 to 33%. It's mostly, there's actually a different mixture now. White and black is 47 to 43%. And non-Hispanic stays the same. And also the same age group we looked at, 26 to 60, is 32 and 41%, with that top group of greater than 60 still at 13%. So this is kind of following the same demographics in certain areas that Collin County did. Our nicotine, alcohol, other breakout is 181,000 for nicotine, 16,000 for alcohol, and then in this case, in Dallas County, the other is actually higher than nicotine. Because remember on the previous slide, it was nicotine, alcohol, then other. There's more drug abuse, substance abuse in Dallas County in this data than there was in Collin County. So we can look at, you can see that the nicotine is obviously the highest, and then you have cannabis, cocaine, cannabis, and smaller numbers. So let's look at the other. So in this case, it's cannabis, cocaine, and cannabis. Remember in Collin County, it was cannabis, and other psychoactives. So we're seeing the same substances in each county. Now this is a little higher. Remember the other one's about 8%. This is probably over 10%, but not much of abuse is in the other category. Now we look at the zip code for Dallas County, and you see we have the same, that other is still the largest zip code area. And then we have the same repeating 75216, 75217. 75243, it actually goes down to the 5th or 6th one there. So we're seeing the same issues in the same counties. Where do these patients go? Where did patients in Dallas County go? Well, we have a lot of resources in Dallas County, so they pretty much stayed in Dallas County. They look like they kept Brad employed at Parkland there with 36%, and then Baylor. So if you put Baylor as one entity, they'd actually have the largest amount. So now we're looking at OSAR data for Dallas County, and you can see that in Dallas County, marijuana and hashish is the highest, and then you have looks like alcohol, heroin, and methamphetamines for the adults. For the youth, and for OSAR data, youth is defined as age 13 to 17, 250 for marijuana and hash. Poison control data for Dallas County, you see the same things that we saw before, analgesics, antihistamine, antidepressants, sedatives, and even the same patient population, less than 5, the majority was 5,814. So our findings from Dallas County. Our total visits were 214,000. 82% of our visits ended up being outpatient visits. That means they went to an ER and then they were discharged home. 73% by age group 26 to 60. Remember, in Collin County, it was about 65, 66%. Based on our data, after nicotine, alcohol, cannabis, cocaine, psychoactive substances, and opiates are the highest. And in youth, we saw marijuana and alcohol. Is that expected? Would you expect a youth, 13 to 17, to experiment with alcohol or marijuana? Yeah, and or, you know. It's the other stuff that pops up there that I wouldn't expect them to do, so. All right, so Hood County. So Hood County is dramatically smaller. Dallas County was 2.6 million. Hood County is 57,000 population-wise. So we look at their high-frequency utilization patients. Their number one patient had 13 visits and came in at 25,000. What I find interesting on this slide, if you go down to number 7, 7 had 9 visits, but there were $112,000 for those 9 visits. Again, these are not just substance abuse, substance misuse. They come in for another diagnosis. All right, they may come in for chest pain or things related to congestive heart failure, and they may drink and smoke or do drugs. Our demographics for Hood County is, again, our N is really small, 1,886. Our average per cost is 31,000. It's interesting here that the outpatient number actually went down. Remember, it was about 80. It was in the 80s for Dallas County. Now in Hood County, it's 70%, and they admit more patients in Hood County than they do in Dallas County. Why do you think that is? Maybe they have nowhere else to go. There are no other resources except for inpatient care in Hood County. Anybody from Hood County? It's kind of a long way, I know. They were discharged to home, 86%, and they are insured 40%, and then uninsured. It's interesting that Medicare and uninsured are basically the same, 22 and 25%. Here again, we're back to male and females are equal again in our numbers here. It's mostly white, non-Hispanic, and Latino. And again, we see the same pattern, 26 to 60, except for one difference. You see greater than 60? It's almost 30%. And in the other two counties, it was like 14, 15%, 13%. It's a large jump of greater than 60 patients. And why do you think that is? What's that? Yes, it's a rural area. They're more stretched out, less support than what may have in an urban environment. That's what we think. So let's look at the substance abuse misuse in Hood County. Again, our numbers is really small. Nicotine is 1,600, alcohol is 110, and other is actually matches. It's 110 also. So what do we see if we break it down by codes? Nicotine is number 1, and then alcohol. And then you see more nicotine. Chewing tobacco is not something we see very often, but it's in there now. And then cannabis is further down, and then alcohol. So if we look specifically at the other category, we see cannabis, other stimulant abuse, uncomplicated. Does that sound familiar? Yeah, we've seen that in every county. So let's look at our zip codes. So in this county, the top 3 zip codes are the same. Now, it's kind of hard to say with number 3 because, so number 3 is possibly they may be in another zip code, such as 76049. They may be in one of these other zip codes. It might not, they didn't disclose, it wasn't checked, it's blinded for some reason. So I'm not saying that 3 is not a separate zip code. It's probably part of all the other zip codes too. But for some reason that information wasn't given. Nope. Where do these patients go? Does this look like they're staying inside their county? The answer is no. They're going to Fort Worth, Stephenville, Fort Worth. These patients, a lot of these patients are leaving their county of record, or zip code, and going to other counties. So what does that mean? Well, that means that these facilities have the burden of the individuals coming from a county outside their own. You know, does that mean, is that a financial burden? Is that a staffing burden? Do we have enough beds? Do we have enough staff to take care of this additional patients that are coming to our facilities? I don't have the answer to those questions.
Is there a reason?
Yeah.
The reason why they're coming outside the county is because they don't have.
Correct. Yeah. So the data that we looked at gave us a patient and what facility went to, and so a patient, a county, and what facility it went to. So that's the assumption we're making is that it may not be that they don't have the care they need, or maybe they don't have the level of care they need. You know, these rural hospitals have, I mean, you go anything more than a broken arm, they're going to ship you to someplace bigger, you know, and that's fine. Appropriate level of care. So our OSAR data for Hood is marijuana and hash, methamphetamines, and alcohol. So they're small communities, they're out, they're lonely, they're at home, the elderly is the highest, you know, part of them, and they drink and they use marijuana, and then methamphetamines. I think that's something you see around the country. The small rural areas, you see a higher instance of methamphetamine. I used to live in New Mexico, and Cuba, New Mexico was the highest methamphetamine use per capita in the country. And it was probably 5,000 people, 10,000 people maybe. So that's kind of the small communities, the rural communities where you see that use. So let's look at our poison control data. Does this look familiar? Analgesics, sedatives, antidepressants. And again, our biggest patient population is less than 5 is 179. It is one of the things that on this one it's different than the other ones is cold and cough preparations. What do y'all think that is? You know, you go to the doctor, you have a cough, and you can't sleep, they give you, you know, guaifenesin, something with codeine in it maybe, and then like Kristen said, those little hands get into it and they drink a little bit of it and they're very, very sleepy, they won't wake up and they call poison control. So our key findings from Hood County is, as it's a small county, it does have the same pattern as the large counties. So 1,800 was their population, 70% were outpatient visit. That is a little different, but it's still on the higher end. 87% were discharged to home, and 10% transferred to another facility or provider. It'd be interesting to see the recidivism rate of these patients that come through the ER, they have treatment, they're sent home, and how often they come back. 64% visits by age group, 26 to 60. Our OSAR data suggests the top 5 substances: alcohol, methamphetamine, marijuana, heroin, and opiates. Everybody awake? Hunt County is our next county. So Hunt County's population is 91,000, so it's obviously bigger than Hood. Our high-frequency legalizations, we'll start with the top one, 35 visits by one patient for a price of $170,000. But as I can present it on the other one, look at number 7, or number 8, excuse me, or 7 or 8. So 18 visits versus 16 visits, 323,000, 513,000. So 16 visits, 513,000. That's a lot of money for a total of $1.7 million per year for 201 patients. Our characteristics or demographics of Hunt County is a population of about 11,000 with a average charges about 13,000. There are 82% outpatient. Discharge at home is 88%, almost 89%. The insurance flips again, where the insured is 25, Medicare is 25, and uninsured is 35. Does that make sense? It's a rural county, You probably have a decent amount of elderly in a rural county, so that makes sense. Here, the females are in charge in Hunt County, 47% to 40%, mostly white, 98% Hispanic or Latino. And the same pattern we see before, 26 to 60, 27 and 39%. So we're having on that high end of age, middle to high end of age, and then 19% is greater than 60. So let's look at the substance that we see in Hunt County. Nicotine is obviously number 1. Alcohol is, actually in this case, it's number 3, and other is number 2. So what are they using in Hunt County? Nicotine, other stimulant abuse. That's one of the things that we found difficult when we were doing the codes is if I tell you, oh yeah, they're admitted for other stimulant abuse uncomplicated, what does that mean? I don't know, and we never figured it out. But the coding experts said that there's a lot of possibilities there. That the possibility that the provider did not code correctly. Number 2, the provider's notes were unreadable, so they had to guess what they did. It could also be an inexperienced coder that coded it wrong.
We had several meetings with UT Southwestern's coding department, and we really appreciate Rhonda Walker,
Yeah.
the director of coding services at UT Southwestern, for guiding us through this.
As a nurse that sees all these diagnoses and whatever, you don't think about the stuff that's on the backside. How does this stuff get paid and whatever? So I've got an amazing education from these conversations. So let's look at what other is. Other in Hunt County is other stimulant abuse, and then cannabis, and then other psychoactive substance abuse uncomplicated. Those 3 or 4 we're seeing over and over in every county as the top 3 or 4. But if you add it all up, that may be 6 or 7%. So it's a small number in a small county. But it doesn't matter, does it? It doesn't matter how big or small the number is. They should be able to receive treatment, the best treatment that we can provide. In a perfect world, I know. So let's look at the zip codes. You see the same thing, 75401, 402, and 474, and then X. The top 4 are all the same. So there's the same issues in every zip code in this county. So what does that do? That allows us to say, okay, well, we have resources. Where's the best place to put these resources at? So if I have 31% in 75401, and I have 1.98% in 75422, if in a perfect world, which one should get the priority? It should be the 75401. Especially like we said, that these are the same numbers we see in poverty numbers and diabetes numbers and behavioral health diagnosis numbers also. So where do these patients go? Can you guess where they go? Well, all of them go to? They all go to Hunt Regional. So Hunt Regional has a burden of all these patients. So our OSAR data for Hunt County, and this time we had no youth data available. And the highest drug class was marijuana, hashish, and then methamphetamines and alcohol. And then our poison control data, we're seeing the same things: analgesics, sedatives, antidepressants, and there's that cold and cough preparations again. Our largest population for poison control calls is the less than 5 years, 310 patients, or individuals. They may not be patients. So our key findings from Hunt County is that it's a small county. We only had 11,000 patients that met criteria in this county. 67% visits by age group, 26 to 60. So we've seen the 3 other counties that we've done, 4, this is the 4th one, 3 have had their age group of 26 to 60 was all in the 60s, and Dallas County was in the 80s. It is a little different. The top substance we see is alcohol, cannabis, psychoactive substances, cocaine, and opiates. Our OSAR data has those things also. 88% were discharged to home, and 9% transferred to another facility or a provider. All right, we're almost done, folks. Thank you for being patient. Tarrant County, our neighbors to the north.
Did we mention that today we are presenting only 5 counties?
Yes.
We want to be mindful of,
You're welcome.
mindful of your time and energy.
So that's a good segue. So on the Healthy North Texas website, the full report will be available, and it'll probably be around 180, 190 slides. You know. Now we can do it if you want.
Yeah, and 190 slides when we have the same information. But I know we have some more partners who are still working on sending data to us. I have Michelle here from Texas Health Aetna, and she's working hard to get us data, and I think this presentation will expedite that process.
So last county, Tarrant County, our neighbor to the north, a population of just short of 2 million. So let's talk about the population really quick, because that actually may not be true today. The population number is from the Texas state of state of Texas, I should say. And it was their prediction for January of 2017 was this what the population of these counties would be. We have experienced magnificent growth here in DFW, so those numbers are probably higher now. So let's just jump to number 7. Number 7, 91 visits at a cost, charges filed. So this is not even cost. Cost can be higher than that to the insurance company, to the facility. Charges filed of $1.1 million. 91 visits. And just so you know, that's separate, okay? So say if I go into the hospital and I'm there for 4 days, that's one visit. You know, we can't assume that he was in the hospital for 1 day 91 times. Probably not. Not with $1 million worth of bills. Let's look at the characteristics of Tarrant County. Are we good? You're good. Okay. You're just looking at me. Case number is 175,000. Our average charges filed was about 12,000. Outpatient, again, we're back up again, 83%. Discharge at home, 90%. Again, this would be interesting to look at recidivism rates in Tarrant County and see how many of those patients come back. As far as insured, it's insured is 32% and uninsured is 43%. Gender, it's pretty close to equal, 40 to 36%, and then white is 60% versus 28% African American. It's non-Hispanic or Latino is about 90%. And then we look at the age groups, 21 to 60 is still by far the largest population. And we have that little bump over the top, greater to 60, about 15%.
One
And
thing I like about this, sorry, I'm interrupting.
No,
but gender
you're the boss.
equality, we don't see very often. Right? We are struggling on gender equality, but you see that here, right?
So let me just make a quick note here too about these age groups. So these age groups kind of came up through many conversations, but one of the things that I don't know if you noticed or not, and I haven't mentioned, but the less than 12 is 0.04%, okay? And even the 13 to 18 is only 1.78%. We actually think that's a weakness in our data, all right? We think for several reasons, and we've had lots of conversations about this, these patients are not being reported. And there's a long explanation about why that's happening, but we actually don't believe those numbers are that low, but we don't have the data to support it if they are. So let's look at what substances they use in Tarrant County. Nicotine is 162,000 individuals, and again, we have other is higher at 19,000 versus 10,000 of alcohol. Nicotine and then alcohol, and then you see cannabis, other stimulants. And the breakout of the other, cannabis, other psychoactive, cannabis, other stimulant abuse complicated. Does that sound familiar? It should. It's like we're repeating the same things over. But you do see in Tarrant County, the percentage in the other category is actually higher than what we see in other counties. So that's probably 2, 3, 4, 5, 6, no, probably about 9%, maybe even 10%. So it's a little higher than the other counties. Our top zip code in the county is, again, we have the undisclosed, and then you can see it's 119, 116, 1112, and then.
Yeah, these were our zip codes when we were doing diabetes initiative, and initiative is still going on, we support that, but these are the zip codes that initiative is. And same thing we found in mental health CHM as well.
These are strictly substance abuse misuse visits. Yeah, it's from that 671,000 and change. From that data set, these are from those visits.
So at primary or secondary diagnosis, substance abuse or misuse coded on any patient visit in 2017.
Okay. So where do these patients go? Obviously JPS and Harris Methodist are the biggest ones. I can't think that's expected. There is some migration though. I mean, the Grapevine is there. I think I saw Hearst.
Still Tarrant County.
Still Tarrant County. But Grapevine is in.
Yeah, we see less patient migration in Dallas and Tarrant County outside than other counties.
Which makes sense because that means there's more medical resources in those urban counties versus those rural counties.
Plus at the same time, these two counties, they have public hospitals, Parkland and JPS. So that makes a huge difference.
So let's look at our OSAR data for Tarrant County. This is actually a little change from what we've seen in other counties. Alcohol is number one in this county. Remember, marijuana, hashish, or methamphetamines were number one in the other counties. So alcohol is number one, and then marijuana, hashish, methamphetamines, and heroin round out the top five. And then youth in Tarrant County, again, this is only OSAR data. So this is only patients that have gone to a facility that's part of the program, okay? Youth-wise, they saw marijuana and hashish is 519. And it's probably more marijuana than hashish. Poison control calls, again, the same top 3 or 4, analgesics, antihistamines, antidepressants, sedatives. That's actually a different one. Cardiovascular drugs and topical preparations are new in that top group. Cold and cough preparations we've seen before. But we see there's still less than 5 is still the largest group that are being called about at Texas Poison Control with a number of 5,300. So our key findings from Tarrant County is that 84% were outpatient visits, 71% visits by age group 26 to 60. So it's a little higher than the other counties. They were in the 60s except for Dallas County, which was in the 80s. And then at 14% by greater than 60%. 32% were insured versus 43% uninsured. The drugs of choice, alcohol, cannabis, psychoactive, and stimulants, cocaine, and opiates. So if I were to have you close your eyes and say, describe a patient, a substance abuse, substance misuse patient in North Texas from these 16 counties, this is what I would hope you'd see. 60-70% visits by age 26 to 60 and 15 to 20% by 60. Greater than 60, excuse me. Insurance range from 26% in insured patients in Dallas County to 45% as the high in Collin County. Uninsured patients ranges from 25 to 48, 48 being the highest, and Collin and Hunt are 25. There's actually a county missing, Hood, and I think it's in the 20s. Non-Hispanic Latino, Dallas has the highest number of non-Hispanic, the second highest number of Hispanic Latino, Hunt has the highest. 79% whites, visits by whites. There is no difference observed based on gender. The common substance of use is marijuana, alcohol in youth, nicotine, alcohol, methamphetamine, cocaine, heroin, and opiates in adults. So now we have this data. We know what they're using in what community. What are we going to do about it? So our suggested strategies to help alleviate these issues, understand the characteristics of substance abuse misuse in individuals. We started doing that by gathering this data, identifying specific disparity in subpopulation with zip codes. We've started doing that also. Developing local collaborative partnership to address local issues related to the most common substance abuse. Well, that's why you're here. You are our collaborative partnerships. Promoting education and raising awareness for prevention and support services. Well, this is an education tool here today to help you educate about your communities and for you to go back to your communities and take this information and say, hey, we need to do this because this is a big issue. Establish partnerships among counties to address common challenges like social determinants of health, severe healthcare issues, access, which we're talking about rural areas, resource shortages, and emerging substances. So we hear about, again, this is only 1 year, and you hear about the opiate epidemic, all right? People may even call it a pandemic because it's in countries all over the world now, too, I read yesterday that they found sweet tarts, little small sweet tarts, actually heroin that they were giving out, somewhere on the East Coast. So it's obviously an issue. We were actually, or maybe I was surprised when we pulled up the numbers how low they were. I was expected to see higher non-nicotine, non-alcohol, substance abuse misuse numbers per county. I was expecting 20%, 25%. So far the numbers are not there. Again, this is a year old, this is 2017. So it might be interesting to say what's going on now.
Also, these are hospital numbers. So
Right.
anyone who went to hospital, these are hospital visits statistics. So, but outside hospitals,
Right,
that's why we are looking for different sources. Once we have payers data, once we have ME's data, I think this will give us more information. Yes, please.
Are you guys looking into like the treatment facilities for adolescents, say like Misuse and Millwood? Are you guys looking at any of that stuff to see if you can gather any data or?
We would love to if we can get that information, because data sharing, information sharing is always a difficult part. So.
Your marijuana and alcohol on your youth side
Yeah.
go up drastically if you had data from those facilities.
Now we do have children.
It's very hard. I work in Johnson County. It's very difficult for us to find a youth facility that'll take anyone under the age of 18 or alcohol or substance abuse. So they generally tend to go to what we term our residential treatment centers, right? The Misuse and the Millwoods and Excels and those kinds of things, and they get treatment for things like coping skills and all those things to try to make them healthier individuals. But as far as having like somebody admitted for substance abuse or misuse, it's just I don't know of any data that's out there.
So I'd love to comment back on that. First off, that made me outstanding so many friends. We want that.
She's a Hollywood.
But second, and I think it's important to know, you're looking at a lot of emergency room visits. Emergency rooms are not at those facilities, those are receiving transfers. So I think it would inform the inpatient treatment, but it would not necessarily improve your emergent intervention or other visits. So they have both Cook Children's and Children's Dallas networks in this data. So those counts are there. And I think that the committee had discussed that there is some stigma attaching commentary about that in the record. And a lot of times providers will not even include it in a record in those fields on purpose to not burden the child with the record. So I think that the inpatient stuff would be actually somewhat instructive in that you might get some of that you might miss for all reasons in an emergency department. But the comprehensiveness of the emergent intervention on the outpatient side is there. Yeah. Sorry.
Thank you. That's why she's the boss. So collaborating on joint funding and policy efforts, that's what these programs based on. So thanks. So at this time, there will be a panel. Am I right? I'm sorry, I'm done. I'll go sit down.
Any more questions?
Yeah.
For our two experts up here who led your initiative. If you had any feedback for the next initiative, the next needs assessment, whatever that topic is, that would improve this process, what would you give to the community and to the leaders here? We have a large population.
I'll start. I was involved with, just about this time last year, with an effort in Dallas ISD where we did the substance abuse part of the YRBS survey with about 520 kids, and that was very informative. There are other school surveys. Texas A&M does one where they'll aggregate statewide data on high school surveys on substance use. But I think that the commenter's point is well taken, that there's data that's getting missed, particularly on youth, that we could do a better job on. So if we could, as great as the hospital data are, and they continue to be, we could look for some complementary data as well.
I think just data in general, the speaker pointed out the need for data, but a lot of that data is very proprietary, and being able to access that data, it can be difficult to even access public record information on the state level. And so I think it's just this ongoing challenge that it is difficult. We want our actions and our behaviors and our initiatives to be informed by the data, but accessing data, I will tell you, is, in my opinion, working on projects is much harder than it was at any point in my career for a variety of reasons. People are opting out of providing data to what used to be very large and informed databases. And so it's becoming a greater and greater challenge to have our work driven by data.
Any other questions for our chairs?
And I'm not sure if it would be appropriate for the chairs or for Dr. Sharma to answer, but it was regarding one of the goals that you had mentioned at the beginning of your presentation, the behavioral health providers repository. Is that only, does that include only members of the DFW Hospital Council, or is that, does those include like private providers?
Anyone.
Repeat the question, the data repository, the provider repository from last year.
Yes, and any provider in all these 16 counties who is providing any kind of mental health or substance misuse related services is listed. And if you go on Healthy North Texas website, you will see that providers registry based on counties. So, and with physical address and contact details, that was the condition. So, yes, that's the. Yes, and I want to thank Dr. Mary Teets. Mary and her interns, they helped us compiling that registry. So thank you, Dr. Teets. Appreciate that. So now, sure.
Well, I was just going to make one other comment, that by using this data set for the hospitals, it doesn't show the number of individuals who are presenting at community-based providers. And those of us that interact on a regular basis with community-based specialty providers in this field know that they run a large wait list. And so it is incumbent upon all of us to realize that when individuals are not able to get treatment for these substance use disorders, it creates a greater financial burden on our hospital systems as their health continues to deteriorate. So anything that we as a community can do to continue to support increasing access for services, I think that it will behoove our entire healthcare system to do that.
Two questions that are kind of related. One, is, I'm with, as far as I'm help you. Related to the opioid use, do you think that it is actually just underrepresented in the numbers, or do you actually, based on the research and information that you got, that actually just is not as prevalent in the North Texas community as we suspect? And then the second part of that, as it relates to the age, the age, I was pretty surprised at that because we have different numbers as it relates to who's using particularly opioids. But do you think that the emissions or overdose deaths have to do with more, it's not as prevalent with younger people and it goes up to the older age groups because they've been using for longer periods and their health conditions start, it shows up more and start having more complications as you get older? Does that make sense?
Yeah. I mean,
So I think the two questions there.
three. Yeah.
Okay. You want to repeat the question? So the first question, if I heard you right, was do we believe that our opiate numbers are low, they're not in line with the rest of the country, or are they an accurate representation of what's happening in North Texas? First issue is that this is a year old, okay? I know the opioid crisis has been growing over time, so this data is from 2017, so we're just over a year. These are only hospital numbers, so one of the things that we tried to get was like EMS run records, okay? So say you have an overdose in the field and they give you Narcan, which is being carried. Narcan is a reversal agent for opiates. They may not transport you to the hospital, you know, so we don't have those numbers in there. And like Jenny said, some of these patients go to other facilities that are not hospital-based. And I like to add to what she says, it would be fantastic to have, so we looked at high frequency utilizations, those high numbers. I bet you a lot of them could be seen in clinics, not hospital-based. So.
I would like to add to the answer of cyber. That is a large number of prescriptions you see in the 16-county area for opiates. It is 3 times larger than the next category.
Mm-hmm.
I think that number that you're seeing accurately represents emergent situations that would bring someone to a hospital. It does not represent an abuse in total context. I think the pure numbers of how many are prescribed gives us an indication that the outpatient area is of more interest here in some ways. And I think your point about the community numbers, the physician office numbers, the who's getting what where, this may be the center point of where we need to look on that topic. However, now I'm arguing with myself. So I do that. I'm an attorney by background, so I know, right? There's a lot of alcohol numbers up there. A lot. And they're showing up there. So my question kind of is, you're getting a lot of alcohol abuse in the emergency areas and in an inpatient setting. And I would think that if the opiates were as much of a problem as alcohol, more would be showing up there too. But I'm not a clinician. And I think clinician questions are part of it.
Like I said, with the mortality, overdose mortality numbers are no way to answer that question. And I don't think it really reflects, we're nowhere near where they are in these states for them.
I just read that the National Institute of Health identified that 60% of individuals with a mental health disorder consume 50% of the opioid prescriptions.
I really
So
don't.
my question would be is whether this data does not show individuals with a mental illness who are also overusing the opioids because the diagnosis might be mental health rather than opioids.
So, lots of hands just so that may be true. So our criteria was, again, was the ICD code, 10 codes of substance abuse is what they call it, all right? That doesn't mean there's not a behavioral health code in there also. We just didn't search for that because that wasn't our topic, okay?
So,
And
building on what
sorry, Ashley, just Sita's question. So last year when we did behavioral health CHNA, we saw 12% overlap between mental health and substance misuse. So that's the population you were talking about when you were saying about NIH data.
So those are different codes. So you're talking about ICD codes, mental health codes would typically be DSM codes. As a therapist, I'm unlikely to send a patient to the emergency room for treatment if I identify that they have a substance abuse or misuse issue. So I think to everybody's point, emergency room visits are probably not super indicative of the amount of opioid issue in our area. So I think like what we're seeing in the headlines, like yesterday I read an article that said you're more likely to die in America of an opioid overdose than you are in a car accident.
Right, which is stunning. We've talked about it.
Emergency room is just really one fraction of where we could get that data. But I think that the data is important because as a hospital council, we're thinking about what ways are our resources and staff a part of the solution. So I think it is helpful to see the impact that the emergency rooms are seeing when it comes to some of these substances, but the larger conversation of how prevalent is the opioid epidemic in North Texas is really one fraction. The prescriptions, I think, say a lot.
So, and that,
I want to make one
Point here on emergency visits. So we look at from two perspectives. If a mental health or substance abuse code is in primary position, then that visit is emergency visit primarily for that. But as we always say, we count any position. And what does that mean? Why do we use that information here or present here or discuss? Because evidences suggest that if a patient was hospitalized or went to emergency room for heart condition, let's say, for example, and has mental health and substance misuse as well at the same time diagnosed, that patient's length of stay, treatment plan, total charges, or let's say cost of care, everything goes up because of these two being in there. So that's why we include that information in presentation as well, that if not solely responsible, it definitely adds up into the overall picture of the treatment plan.
Okay. So that's a great question. We've had numerous conversations about it, and we haven't been able to capture. So basically the question is polysubstance abuse. You know, how do you go in on a patient that has 5 or 6 different uses? They drink, they smoke a little weed, they whatever, I don't know what else. How do you capture that? In our data, the data set we had, we talked extensively, we talked to our data people, and we just didn't have an accurate way to do that, to look at all the codes across all the data to do it. But do we know what's there? Yes, we know what's there. We have no doubt there's polysubstance abuse. To what degree, this data that we looked at for this project, we don't know. And the other thing that we talked here too about other places in the country saying that the opioid crisis is larger there, they're having the same issues too, is about collecting data and what data they use. This is not just a hospital problem or an EMS problem or a clinic problem. It spans a whole spectrum of care. You know, so we're asking this whole spectrum of care to give data to individuals and then we can crunch it. That's just not happening from our point. And then back to your question about are we seeing changes? I think the second question was, yes, so attributable death, me and Brad had a conversation about this. You're right. So the attributable death numbers that we had for, say, Texas, okay, alcohol, drug and alcohol attributable death. It's not just drug and alcohol. Like I said, they may drink for 40 years and develop cirrhosis, and then they die. You know, or they're in the healthcare system with cirrhosis, or some kind of cancer, or they may be drunk and wreck a car. You know, those numbers are not. We didn't look at those numbers either, but that's definitely part of the attributable death right there. I think we had a question right here.
Actually, I had a question about whether or not there were, by the way, my name is Ilka, I'm the director of pharmacy in the Methodist Health System.
Oh, welcome.
And I was wondering if there were any plans to drill down again the opioid information that you gathered. There are several initiatives going on in different health systems to establish or grow our opioid stewardship initiatives. And I think that while we can look at internal data as far as what our prescribers are sending patients home on, I think having the information from the community and seeing what patients are actually filling and you know, the drugs that are involved and even down to the detail of doses, durations, things like that, I think that will help inform us to really drive some initiatives on the health system.
I agree, and you know the data we got from the pharmacy board was very helpful, but it didn't go past the drug class. It didn't give a specific, you know, the names put on there, I put on there because I knew what they fit, but we didn't get them from them. So I don't know. You know, I think it'd be great to drill down and say, you know, what are you prescribing? What exactly are you giving? You know, so something else that's, we're talking about prescription and opiates, we're seeing a backlash the other way. A lot of pain doctors are so scared. Physicians, providers, clinicians are so scared about being talked to by the government in some form that they're reducing their patients. My sister-in-law is a chronic pain patient. Her physician reduced her pain meds 15%. Every pain patient he had in his practice, everybody 15% across the board. Now, some of them probably didn't need all the meds, but some of them do need it. So I think that's kind of the flip side of the opioid crisis. These doctors are scared. These providers are scared about what could happen to them, so they're pulling back. Now, what is that going to mean? Well, that may mean that these chronic pain patients end up in ERs again, you know, because they, you know, I can't take this pain anymore. I'm going to go there. They'll give me something. And they're usually complicated pain, so that makes it even harder. Any other questions?
I guess another point, I don't know if you guys have any feedback on this, but as we're looking at the opioid use and the number of prescriptions, and as doctors are starting to prescribe less, so then the other part of that is what happens to the folks when they can't access the opioids anymore. Then I saw some big high numbers there for heroin use.
The literature is supporting, yeah, that they're moving over to illicit drugs. And see, the problem with illicit drugs, so you're having these people take, I think it's heroin, but it has sufentanil in it. All right, sufentanil is, so morphine is, say, one, the pharmacist can help me here. Pharmacy, on morphine, 1 milligram, so 1 milligram of morphine is 100 milligrams of fentanyl, right? Is that so right? Sufentanil is even a factor higher. We're talking about micrograms. So 1 milligram of morphine is 100 micrograms of fentanyl. Sufentanil is maybe 1,000 or something in that ballpark. I mean, we're talking about incredibly small amount being mixed with these other street drugs, and it's killing these people because they don't know what they're taking. There was a recent story in the news that this young man took two of them took a Vicodin, you know, and it had sufentanil in it, and they didn't wake up. But yeah, so there's a lot of drugs being prescribed, providers are pulling back, patients are looking for other resources, and sometimes they go outside the normal chains and they get to the illicit drugs. And on that note,
Thank you, Scott. Thank you. Thank you, Ben.
Thank you, sir.
So I want to take this opportunity to thank my organization, Dallas-Fort Worth Hospital Council Foundation. When I moved here 5 years ago, I was surprised to see this unique data asset here at the foundation. I want to thank all health systems for participating in this data initiative. Because of them, we are able to do this kind of analysis, which is something like this I've never seen in my research career, past 18 years research career, I can tell you that. And I'm truly enjoying it. I know Teresa doesn't like that because she keeps getting more and more requests from me. But this is an amazing asset, and thanks to all health systems for participating. For new members who do not know about this data warehouse, I'm going to give a brief description. This initiative started back in 1999 and 2000, and since then, all health systems have been sending their claims data to Hospital Council Foundation, and we capture around 97% of North Texas hospital market. And 98 hospitals, over 100 now, Teresa, right? 98 hospitals. And so far, we have 70 million hospital visits in this data warehouse for 11.5 million patients. So you or me, anyone visited any of these hospitals, we will have the information. We use RIMPI, Regional Master Patient Index, to track each and every patient's longitudinally. We have ability to track, and we use this information for longitudinal studies, population health, and through BI tools, we share this information back with health systems. They are able to track the identified data and use this for their strategy decision making or market share analysis. So this is a really comprehensive data warehouse, and we really want to thank our contributors for that. So thank you so much. I want to thank Data and BI department for supporting our research. They've been very patient. I know, I mean, inside what they think about me, but that here comes Sushma again with a crazy idea. Thanks to our leadership for supporting Community Health Collaborative. Thank you, Kristen, for saying yes to any and every crazy ideas. I want to thank Dr. Mary Teets for her support for our Community Health Collaborative work. Mary and her interns, they helped us through Texas Women's University's internship program last year for generating providers registry. And this year for this CHNA as well. I also want to thank, as I mentioned, UT Southwestern's coding department. Rwanda Walker, Director of Coding Services, has been very helpful, and we really truly appreciate her help and support. And thank you to their team. And of course, I want to thank Scott Wells for all his hard work. I can't give you PhD degree, I wish I could, but I wish you well for everything you do. So now we will move, with that said, we will move on to the next agenda item, and that is Dallas Smart Justice Project. I would like to invite Alan Moore to tell us more about this project, which is a unique project for managing and planning treatment more efficiently by sharing information between health systems, local mental health authorities, justice system. So I'll hand this over to Alan Moore. Thank you, Alan.
Thanks. Glad to be here. What a fascinating discussion. It's a lot of data, but they say the devil's in the details. It certainly is. And so I think there's a lot of great insights to pull from that. Now, I've got to figure out how to get my slide up. Yeah, it's a loopback one, sorry. All right, perfect, thanks. So I'm going to spend about 10 minutes, give you a quick update on Smart Justice. It's been, a fantastic, I'd say, Kristen, maybe 15 months or so that we've really been working very hard to get this Smart Justice program up and running. I've been very privileged. I'm the Chief Operating Officer of Loopback Analytics, and so Loopback, I'll skip the next slide, is a software as a service platform. We're based here in Dallas. We're always excited to be working in our own backyard, and we are the technology underpinning for the Smart Justice program. We work very close with Hospital Council as well as the Meadows Mental Health Policy Institute over the past couple of years to put this intervention, this network together, and working with all the partner hospitals that are participating as well. So just really quick, like I said, we're software as a service. We're taking all that real-time admission, discharge, transfer data from the hospitals coming into the Loopback platform. We are taking encounter data from the North Texas Behavioral Health Authority and from their mental health providers. We're taking bookends and releases from Dallas County Criminal Justice, and we're taking that all into the platform. And so part of the question might be, okay, why? Why did the Caruth Foundation see this as being such an impactful area that it chose to invest in for the past 2 years? Well, part of it is some of the problem dimensions at the system level are huge. And I won't drain this slide, and I'm happy to send this to anyone that would like to see it, but it's that same story. A very small subset of individuals drive high utilization, high spend, have high service needs, and in this case, they traverse multiple parts of the service providers, whether it be hospitals, mental health authority, jail, homeless shelters. And what we saw and what the Meadows Mental Health Policy Institute saw was, in their initial analysis, was that this very small cohort of individuals, typically severe and persistent mental illness that's untreated because you have a hard time finding them at the point of service, often substance abuse or misuse issues, homelessness, uninsured, all are part of that group. So the network that was put together, that Loopback is the underpinning for, was to, as these people cross these different points of service, be it Dallas Police call in the field and there's a mental health practitioner there, that's a point of service. It might be in the emergency department where we're seeing these individuals present. It could be presenting in the jail. How do we establish continuity of care so that we all have insight into what's happened to that patient? And this next chart is one that, back to the Hospital Council data source that Teresa helped me build. This shows the day in the life of one of these types of individuals. Sorry, a year in the life. In fact, this is only about 9 months. And what you see is this is across North Texas. Each one of those dots, each one of those lines as it builds is going from one hospital to the next. So you talk about migration, here's what the migration looked like. But here's what we saw that in hindsight. With the network that's in place through Smart Justice, we can now see that in real time. So our objective was to find these individuals that potentially qualify for services, that have untreated mental illness, and get them into service as quickly as possible. And as this slide builds out, you'll start to see some pretty interesting statistics. There are 22 instances where they had 2 or more emergency department encounters in one day. So some individuals are pretty mobile, right? Sometimes traveling 30 to 50 miles. But here's some other things that start to jump out and really start to tie in with what Scott and Sushma were showing. Look at this. What's one of the highest recurring diagnoses for this individual? Unspecified pain. If you're in the emergency department, if you're looking at this data, what would that tell you? Could this be a drug-seeking behavior? Perhaps. Don't know. If you're looking at it from a public health perspective and you start to see this person has Hep C, right? Is it under treatment? If it's under treatment, are they adhering to the regimen? Because Hep C treatment's not an inexpensive proposition. And as we pointed out earlier in the discussion, bipolar is a comorbidity in many of these encounters. So we're seeing this across the board. What's missing? You guys already pointed this out, and what we hope to have in this data set in the coming year would be discharge medications. Parkland and Methodist have already talked about providing that as part of their ADT feed, so we would know what they left with. So when this person left Parkland, did they leave with a script? Did the script get filled? When they presented at THR and ASL, you'd now know that, right? So a lot of this is about awareness and visibility. We see this in the emergency department side. I mean, being very hospital-centric with the start, you know, these patients tend to stay longer in the ED. Sometimes it's waiting for a mental health provider to do an assessment or to show up. They tend to consume more services. So really, what this is all about is putting the tools in place to let us really operate outside of our silo. Sorry about that. So where do we get to by the end of 2018? Secure and compliant shared data. So Parkland, Methodist, THR, and Baylor Scott and White, just coming on board right now, are all providing their ADT data. In addition, we're leveraging the Hospital Council's historical charge data that everyone mentioned. It's a fantastic repository that actually gives us a basis to see history instead of having to watch it be created. So now we have something to go back against. We're now able to rapidly identify these targeted populations. So again, you know, the original Caruth grant and the work with the Institute was very focused on some very narrow cohorts of individuals. We're actually now seeing those people, getting them into service more quickly, because when they present, you need to act quickly. And that's back to this rapid engagement into community-based services. But the big part of, I think, what we spent so much of the past year on is just getting at the system level, right, between hospitals, between public entities, between mental health authority, between mental health providers, between the jail, get the processes aligned for care continuity so we now know the handoffs. We have the data. We can notify you, make you aware of it. Let's make sure the handoffs happen. So, you know, just, I won't drain this slide by any means, but, you know, the foundation's in place from a technology and data standpoint. The processes have been aligned. We're now operating this for a narrow cohort of individuals. It has the potential, you know, as other use cases, say we want to start looking at these instances of unspecified pain and discharge medications for opioid. That could be a potential cohort to monitor and treat. Great news is, you know, we started in Dallas with North Texas Behavioral Health Authority. We've had fantastic conversations with the other counties and their mental health authorities about getting engaged. 2019, we really want to look to, you know, get that North Texas-wide coverage so we actually have the visibility to individuals and able to get them into treatment. So anyway, lots more to tell you about that, but I'm going to be respectful of your time because I think I'm between you and lunch or maybe another presenter. So happy to answer any questions. I think my information is probably on the website. So thanks.
Thank you, Alan. I truly appreciate that. And I know we are running out of time, but I want to invite Jenny to give us a little brief about what her work is. Any update, any highlights? Since you come all the way from San Francisco, I don't want you to leave without telling us something.
Thank you. I know I'm keeping you all from lunch, so I'm going to be very, very, very brief. I'm going to blow through these. Thank you so much for having me. It's really inspiring to see the work that you're all doing and the commitment you're all making to mental health and behavioral health and substance abuse. I am really inspired. So I'm VP of Community Health Solutions with Healthy Communities Institute. Now we're part of Conduent. I'll just skip through this. We work all over the country in different consulting and services capacity. We have technology. You guys have the Healthy North Texas platform. So what I just wanted to spend 2 minutes today is just kind of bringing your eye to what's new. So let me just skip through here. This is what's new. So on the left in the upper navigation, Community Health Collaborative, Sushma's been working really hard on adding in a lot of content there. So a lot of this work, you can find everything you need. In the drop-down, we've got the annual review, the recast project, and the behavioral health CHNA. So just know that this is a place where you can go and find the latest information. As reports are getting created, as slides are getting created, we'll make sure to keep this updated. The other thing I wanted to make sure you know about is this Dallas Community-Wide Data Initiative. And so this is a lot of really interesting, cool data at the block group level for the data for the Dallas area. We've got indicators that are measures of resilience, commitment, and amenities. And these are new indicators using our existing platform technology. And then we've also been working with Sushma's folks to get some different indicators in that are, they look completely different. I'll show you an example in a second, but this is indicators at the block group level. So there's education, community service, health, and economic and public safety indicators. And this is an example of what one of the indicators looks like. So it's very different from the rest of the website. You've got this great mapping, you've got the scatter plot and a graph as well. And this is again at the block group level, so smaller than census tract, very small geography. And these are some upcoming indicators in the measures of resilience, commitment, and amenities. And I think that's all I want to talk about today, is just show you those couple new things. If anybody wants a tour of the website for your organization or anything like that, you can reach out to Sushma and she'll connect with me, and I'd be happy to do that. Some of you know the website, and so you've seen it, and some of you haven't, so I don't want to be repetitive, and I know we're over on time. So thank you so much for having me.
Thank you, Jenny. We truly appreciate yours and rest of your team members, Kara, and everyone else's support. We appreciate that, and thank you for sponsoring this event today. Thank you for coming all the way from San Francisco to be part of this event. And with that said, I want to thank you all for attending this event today and being part of Community Health Collaborative. We appreciate your time, your support, your help, everything you do for us and out in the community. So it's time for lunch. If I have Kristen's permission, I would like to say thank you to you all. Thank you. If you have any questions, please send me an email and I'll be happy to answer and respond immediately. I know Lisa is smiling because sometimes I don't respond immediately, but that's okay. Thank you all. Thank you so much. Appreciate that.